So a very warm welcome to all of you, and we'll be starting our IC, which is called Building a Premium IOL Practice, a Practical Approach. I'm Dr. Ritu Aurora from Delhi NCR, and our aim of this IC is basically called LEAD. The idea is that we need to all learn together, evolve, apply what we learn, and then come back and discuss, so that each of us can help each other to improve our knowledge, our skills, and evolve. So we've started this. First talk will be by Dr. Parul, and Dr. Parul Sharma is a very prominent cataract and refractive surgeon. She practices in Gurgaon, and she'll be talking us about the pre-operative workup for premium IOLs. So Dr. Parul Sharma.
Good afternoon, everyone, and thank you, Dr. Ritu, for this opportunity. I think it's perhaps not an overstatement to say that cataract is one of the most common refractive surgeries these days, and every single cataract surgeon is now aiming that to make their patients as spectacle less dependent as possible. So I'm just going to put up my slides now, and as they say, if you begin well, then it's half a job done. So let's start by pre-operative workup in the premium IOL patients. So it's not just about 20/20, but it's also about giving them distance, intermediate, and near vision at all points in time. So apart from the standard pre-op cataract workup, which you all know, a detailed history about which I'll be talking about subsequently is very important. What all to look on slit lamp, how to make a note of pupil size, because all said and done, we still have some premium presbyopic IOLs which are pupil dependent, whether they'll accept EDOF, how much of their diffractive rings will be exposed. So we need to look at that. I'll also be talking briefly on how to refine your existing biometry to get the best out of your premium IOLs. A pre-op imaging system, if you have video on to how to do that. Corneal tomography becomes a very important part of your patient's workup in premium IOL surgeries. And of course, rule out any posterior segment pathology, because you may have done the best of surgery, chosen the best of the lens, but the outcomes will get compromised if you miss that. So what all do you ask a patient for? You have to ask a history of any chronic dry eye, especially autoimmune disorders which may be associated with ocular surface disease, with the impact the outcomes, any drug intake, especially if patients are on any kind of psychiatric drugs, because these presbyopic IOLs have a time to adopt. So you should be aware of that. History of diabetes, and of course, occupation, lifestyle. We've heard so much about how to plan what kind of lens depending on their visual requirement. One favorite point is the socioeconomic status when people talk about premium IOL, and I have not written and added that because over a period of time I've learned by experience that don't judge patients by how they look. They may be appearing as if they don't want to choose that lens for the cost factor, and later on after the surgery they may come around and tell you, doc, you didn't offer me the best of the lenses. So give the option of premium IOL to all patients, and then it is their prerogative to choose or not to choose out of them. So we start with ocular surface diseases. So when you're on the slit lamp, start from the lid. Rule out any meibomian gland dysfunction. Look at the tear film. You know how to assess your tear films on the slit lamp. That's very important. Do not miss that, because again, I repeat that you may be using the best of lens, but if a patient has dry eye, irritating eyes, the tear film is the first refractive surface. So if that's not adequate and healthy, again, your visual outcomes will be compromised. So treat that first before getting your patient on to your biometries. First, treat any ocular surface. So you have various instrumentation, and I've put a list of things that you need to take care in the pre-operative workup. And this is, I'll show you how it can affect the biometry. So this is one of our patients where when we first did the biometry, it was an acceptance of 21 was an E-metrope, but post dry eye treatment, you can see that there is one diopter of difference. So imagine he pays more, you do the best of lens, and he still has one diopter difference. Similarly, again, a patient before treatment of OSD, after treatment of OSD, you can see that the first biometry says that take a T5 model. Once you've treated him, the same person is accepting a T2 model. So this is just to emphasize that before doing your premium IOLs, even the biometry and deciding the power, treat their dry eye, treat their OSD. Now, how do you refine your current biometries? So optical biometry has made our life much more easier, but do not fret if you do not have optical biometry, please take out the immersion of your biometries. It gives you as accurate axial lens. You do not applanate your cornea, so you do not cause errors there. In your kerato reading, yes, you do need a topo, because just one keratometry reading is not enough, because then you're taking only anterior corneal curvature, and we know how important the posterior corneal curvature is. Get into account 50 of your cases. Just take your pre-op kerato and refraction, do your post-op refraction and kerato. If you don't do the online tools to calculate SIA, personalized confidence, just give it to any of the top company peoples. They will do it for you, and you can have your own personalized formulas. So these are as many points you can make error in biometry, but the take home from this slide is spend more time, re-educate your optometrists again to spend more time on how to calculate and refine your biometries. Now, if you have an optical biometer, how many times have you checked the calibration? It's a must to do it weekly. For example, we have LensStar. It would not make you function till every Monday you have calibrated the machine. How many of us have looked at the head tilt? How many times the optometrist makes sure that the patient is sitting straight, especially in a busy OPD? There are enough studies and publications which say that even a 5 to 15 degree of patient's head tilt will affect the steep meridian of your axis when you're planning the toric lens. So here is a patient. For demo's purpose, we've done the toric with the head tilt in the first picture, and you see the axis here is 72. We put the patient straight, meet the lateral canthus onto the machine, and you see the axis has changed to 82. So do go back home and tell your optometrist that please make sure that the head tilt is not there. Similarly, in acquisition, take out the outliers. For every single acquisition for your axis, axial length, kerato, pupil barycenter, there will be 5 readings. Out of them, if 1 or 2 is highlighted as being an outlier, you remove them, and then you get your accurate reading with minimal standard deviation. It's important to be aware of angle alpha and kappa, especially for premium presbyopic lenses. So alpha is done only by eye trace. Most of us don't have that, but at least look at angle kappa, which is given by the pupil barycenter in most of the optical biometry machines. So initially, before few years, we didn't have optical biometry, but at least for our premium IOL patients, we used to send the patient next door to get one. So that's what you can do. If you don't own one, make friends with somebody who has an optical biometry. So this was the conventional way of doing the IOL formulas. Thankfully, we don't have to put our mind so much now with the advent of the Barrett suite, which is again online. So you can have your A-scan routine biometry, but do the immersion, take the kerato, use the topo readings, go online, put the readings, and you will be 99.99% correct without expensive machines. So these are the 2 platforms that you can go on and calculate your IOL powers. For toric IOLs, make sure that the steep axis is correct. First, you do your topo to rule out any kind of irregularity. Patient should not have keratoconus or irregularity. And why topo? Because there is a fixed assumption in the routine formulas on the anterior and posterior corneal curvature. But we know that posterior astigmatism by itself acts as a minor cylinder and either adds or subtracts to the width rule. So here is a case where the patient has almost the similar astigmatism. So you would think like a 0.86, 0.93, I'll have a small toric or non-toric. So in the width rule, you can see here that there's a non-toric and a similar kind of astigmatism. But against the rule, you've seen that the machine has told you to select a T3 simply because it's adding on to. So against the rule is A. I remember A for A. Against the rule adds on, and with the rule astigmatism, it kind of becomes lesser power. Now, we are always in a little flux when you see a 0.5 astigmatism, whether to do a routine spherical or should I go for toric. So you go on to the toric planner in your instrument, and it will tell you how and when you can modify your incision. So here is an example where there is a small astigmatism, and on the chart, the machine first tells me to pick up a T2 model, but I am manipulating my incision, and if I put it on the steep axis, I may also increase to 2.4. It becomes a non-toric model there. So this is also something which you can go back and look on the machines, how to plan your astigmatism in small amount of astigmatism. One word about the premium lenses in post-refractive patients, because the more LASIKs and PRKs out there, all of them are going to get old and get cataract. Not even old, I mean even younger people are coming to you post-refractive. So again, you can go online, and Barrett True-K is the formula that you choose. You don't even need the history and other previous details. If possible, if you can have access to Pentacam Holiday, it's good to look at this map, because then you can pick out the 4.5 millimeter, because here the anterior posterior curvature post-refractive is all altered. So the normal formulas don't work. So you can take the 4.5 and go online and feed this. It also tells you the X and Y plot, again to rule out angle kappas. So you wouldn't want to do in a large angle kappas any kind of presbyopic lenses. And it also gives you the mesopic pupil size. So all these are clues which help you to make your practice better. Now you've done all that and you've put these trifocals kind of lenses, and the patient still says that it could be either of these problems, and he will say, Doctor Sahab, kuch maza nahi aaya. And so what do you do so that he doesn't end up feeling that? So I don't like the word counseling, because we are not here to counsel. We are here to give them visual results also. So I say prepare the patients mentally, right? So talk to them, prepare them for all the outcomes, pros and cons. More expensive doesn't mean that each lens has its own little shortcomings also. And when you talk to the patient, you should make him sure that he understands that I am concerned about your outcome, your visual outcomes. It's not that extra cost which is coming with the premium lenses is my primary gain. So tell them that it decreases your dependence on glasses. Never use the word get rid of glasses. That's a very strong statement to commit for. Explain the technology, not so much about the lens and the company. Explain about your technique, your technology. I do it this way. Don't glorify the company. Glorify your skills. You've taken decades to reach where you are. It's very good to have digital source. Gone are the days of those printed brochures in the OPD. Like, you can put on as much stuff as you want on YouTube's, on your website, and it's very important to give them a link. One, it's very easy for patient to wait in the OPD and just scroll through what is there on his phone. Two, whatever you want to be on social media and promote your eye clinic or website, every patient you give a link, while they are waiting, they just tap on it and read about the lenses that you have offered to them. So you're also increasing your web presence, and you don't have to go and hunt somebody for SEOs. When you're doing presbyopic lenses, tell them that it may take some time. Even when you go for new glasses or contact lenses, there is an adaptation time. So in the first and second week, the hell will not break loose if they have a little waxy vision or negative dysphotopsia from the side, because they are already informed. And in today's era, informed consent is very, very important. So if we have prepared the patient mentally, it's very important to prepare yourself also, because somewhere we are also stuck. When the patient is paying you a lakh, 1.5 lakh, you're scared. You just automatically take a back foot. So when you're well prepared, your confidence comes from within, when you know the machines, when you know about the technique. So prepare well, refine your technologies. Dr. Ritu's IC, more attend of her ICs and learn. Take feedbacks from people who are already doing those premium IOL. Suppose there's a new entry, like there's so many Indian multifocals, trifocals coming now. You don't want to burn your fingers initially. Let other people create mistakes and then learn from their mistakes. Again, I would say that you are the best counselor for your patient. Extra 2 lines and 5 minutes with you will give him much more confidence than sending him to another room and saying that my counselor will explain. So this we have heard many a times in so many talks, that under promise and over deliver. And either ways, it's a journey. So enjoy that journey. And I think I've set the platform for the other speakers to come and explain to you more. Thank you.
Thank you, Dr. Parul. That was really an excellent talk. I think she's completed everything possible that one could want to do for a premium IOL workup. And one or two points that I would just like to add is, now that we've been doing so much of refractive surgery, always ask positively for a history of whether you've undergone refractive surgery. Many a time patients will not come forward and tell you, and sometimes you can even miss in your slit lamp examination. You may not be able to see it. A patient may have undergone PRK or even LASIK. You may not be able to see the flap. So always ask for your history. And the other thing we could do is higher order aberrations. Like if you have access to Pentacam and you're doing a premium IOL, it's a good idea just to get an idea of what the higher order aberrations pre-existing are. If they're already high, that patient may not be an ideal candidate for multifocals. So thank you so much, Dr. Parul, and please accumulate your questions and we can take them all in the end. So I invite Dr. Bhalla, who's our secretary, dynamic secretary of Delhi Ophthalmic Society, and he'll be talking to us about biometry and IOL formulas, getting it right.
Thank you, Dr. Ritu, for having me in your such a nice introduction course. I'm going to talk on the IOL power calculation formula for perfect outcome after this beautiful talk by Dr. Parul. We all know cataract surgery is a refractive surgery. In earlier times, cataract was removed first and spectacle prescription given last. But today we calculate power of IOL first and cataract surgery is done afterwards. And since 75, IOL power has been calculated basically using two parameters, that is keratometry and axial length. But today we use more parameters, and today we can customize the power of IOL to achieve near plano result even in highly myopic or hyperopic eyes. But there are a group of patients who greatly value their emmetropia, and when you break news to them that they require spectacles after cataract surgery, because of inaccurate IOL power calculation, they are extremely disappointed. And what are the major sources for prediction error for IOL power? The foremost important part in 35% patients is prediction of effective lens position, followed by 17% because of axial length and 10% because of keratometry measurements. And few subjects in the field of ophthalmology are as complex as IOL power formulas because it involves the use of mathematicians, and we ophthalmologists by nature are not very fond of mathematics. Earlier formulas had some problem. They made some assumptions. That one is, as pointed out by Dr. Parul, they assumed fixed ratio of anterior and posterior corneal curvature of 0.82. Cornea was treated as a thin lens with refractive index 1.3375. Actually, it is 1.37, and cornea was treated as a prolate sphere. This used to give us correct result in average eyes, but not in atypical eyes. And there were some more hurdles in accurate estimation of effective lens position, because it was assumed in older formulas that shorter eyes and flatter KIs are supposed to have shallow anterior chamber and shorter effective lens position, in contrast to longer eyes and steeper KIs, which are supposed to have longer effective lens position. But Holiday taught us that there are 9 types of eyes. Even in eyes with normal anterior segment, 80% may have short axial length and 90% may have long axial length. And in patients with normal axial length, 2% may have short or deeper anterior chamber depth. So relationship between anterior segment size and axial length is not proportionate in 80% of short and 90% of long eyes. So older formula are bound to fall in shorter and longer eyes. So is it bad to keep just using the older formulas? Yes, it is, because the survey told us that only 1% of surgeons achieved accuracy more than 92% within plus minus 0.5 diopter if you keep using the older generation formulas. This was Rayner made a lecture delivered, and they said now it is possible to achieve 91% of eyes within 0.5 diopter of the target refraction if we change with the technology. So what are these new formulas? Hoffer H5, Ladas, Olsen, Barrett, Barrett Universal 2 and Hill RBF calculator. Prediction theory says more the number of variables to describe an event, more accurately the outcome can be predicted. So we have jumped from 2 parameters of axial length and keratometry in 1988 to 4 parameters in Olsen, 5 in Barrett Universal 2, and Holiday 2 has 7 parameters. Artificial intelligence is used in Hill RBF and ray tracing in Oculus and phaco optics. And there are some intermediate factors that have been used to assume or arrive at effective lens position. While SRKT had A constant, Haigis and Holiday 1 has personalized, Haigis has A0, A1, A2, Hoffer Q and Holiday 2 has anterior chamber depth, Holiday 1 has surgeon factor, Olsen has C constant, and Barrett has lens factor. So what are these lens constants actually? These were typically developed during the later stages of regulatory process with short-term and limited number of cases when plano-convex lens were used and contact ultrasound biometry was used. So if we have only the manufacturer's lens constants, then when we do get some error. So it makes sense to optimize your lens constants. Either you can analyze your own data, or you can go to the www.drhill.com or Dr. Haigis ULIP website. Surgeons who do not personalize their constants, 50% of their cases have error more than 0.5 diopter. So you see on the left hand slide, if you don't optimize your constants within 0.5 diopter, it is only 18%, and this jumps to about 70% if you optimize your constants, and within 1 diopter it changes from 50 to 95%. That's a huge difference in your results. So what is this Barrett Universal 2 formula which everybody is talking about? It is recommended for both short and long eyes, and it has Betti's keratometry, axial length, anterior chamber depth, lens thickness, and white to white measurements in that order of importance. It it uses artificial intelligence, and it gives us predicted accuracy of 91% of eyes within 0.5 diopters. Olson uses ray tracing. Lada super formula intelligently combines the best performing portions of multiple third and fourth generation IOL formulas. Kane formula uses axial length keratometry, anterior chamber depth, lens thickness, CCT, and also gender of the patient to make its predictions. EVO 2.0 formula, it is a thick lens version formula, and it also uses these parameters, and it is also being quoted hugely in the current literature. Intraoperative aberrometry is not going to make lens calculations obsolete in the near future. At best, it is valuable as a confirmatory or complementary test, and the indications are in post-refractive surgery cases and in astigmatic correction with toric IOLs. Ray tracing IOL calculation formula is equivalent to third generation formulas in normal eyes with spherical IOLs, but it is definitely superior in odd eyes with extreme axial length and corneal conditions, and it's incorporated in oculics and phaco-optics. But there are limitations of ray tracing formula. That is, they are still dependent on accurate estimation of effective lens position, which is still a bugbear, and so there is no reason to switch as they are not outperforming the standard formulas. Hill RBF formula is good because it not only gives you IOL power, it also gives you accuracy level. It tells you whether your results are in bounds or out of bounds depending on whether your patient's data parallels the data within the data bank, or it is not, then it is out of bound indication. So if we compare Barrett and Hill RBF, both are current, both are more sophisticated, although they use completely different premises. Like Barrett uses artificial intelligence, and Barrett is a theoretical paraxial formula, and Hill RBF is using artificial intelligence. But both these methods give recommendations that are within 0.25 diopter of each other. So what should I do? Should I use multiple formulas and average the results? Douglas Koch follows this policy. He uses multiple formulas. But Holiday Barrett says use horses for courses premises. That is, use specific formulas for specific condition. So what is the best way to deal with short eyes? Older conventional wisdom told us that use Hoffer Q, but now it has been replaced by the publications in the recent literature which are more using Barrett and Hill RBF. And problem in longer eye, we also know that there is hyperopic surprise when dealing with eyes more than 24 millimeter. So the three formulas which work well are, again, you can just remember Barrett Universal 2 and Hill RBF, and all these new generation formulas are free of cost, available on site. You don't need to spend like Holiday 2. This is meta-analysis which has been published in 2022, and you can see in order of preference with shorter axial length less than 22, between 22 to 26, and more than 26. You will find that SRKT and the older generation formulas are not there in the first 5. The best performing ones are the Kane, EVO 2.0, VRF, Barrett Universal 2, Hill RBF, and they're followed by other formulas. Same thing was reciprocated by publication of Meles in 2009 in JCRS. And so what are the steps you can take to maximize the likelihood of getting better outcomes? Please optimize your lens constants, validate your measurements if your readings are beyond the normal. That is, if your axial length is in extreme less than 22 or more than 25, keratometry less than 40 or more than 47. So take measurements yourself, because ophthalmologist is the most important and knowledgeable part of the team. Don't delegate it to your optometrist, particularly in premium IOLs and VIP patients. Spend extra time counseling patients with short eyes or previous refractive surgery, as told by Dr. Parul, and don't just keep doing what you have always done, because then you will get the same error which you have always got. So 90%, but why we are still stuck at an accuracy of 90% within 0.5 diopters and not more than that? Because limit is now not the formula. We have got very good formulas. Limit is the precision limit for keratometry, because the least count is 0.25 diopter. For axial length, it is 0.1, and for anterior chamber depth, it is 0.2 millimeter. So these least count error limits keep us at accuracy level of 90% plus minus 0.5 diopters. And then there is another problem. There is ISO permitted tolerance level permitted for various powers. If suppose I have calculated power of 21.3 diopter, nearest power available is 21.5, and ISO tolerance limit for this is 0.4. So I wanted to implant 21.3, but because of this tolerance permitted, the error will be 21.9. So it is 0.6 diopter error when I have done perfect calculation, good instruments, good surgery. Still, this error is for reasons beyond my control. So have we reached a stage where we can use single formula? I'll just take a minute more. Where you can use single formula for all eyes, difficult to say, but the closest formula which fits the bill is Barrett Universal 2. So this is slide has been shown that these are the formulas which are outperforming the earlier generation formulas. So improvements in technology have allowed accuracy of biometry to double every 5 to 10 years. So we should change for the better. 80% accuracy was acceptable in the older times, but now 90% accuracy is achievable. So strive for what is achievable and not settle for what is acceptable. Smartness is learning not only from your own but also from others' mistakes. So let us not only become experienced but also smart. So we are now on the verge of level of accuracy for refractive outcomes after cataract surgery never before seen in ophthalmology. But to fully enjoy this, use validated measurements, optimize your lens constants, and adapt to newer technologies. We should be thankful to these ladies and gentlemen for giving us this level of accuracy: Holiday, Wang, Koch, Warren Hill, Thomas Olsen, and Barrett. Thank you everyone for your kind and patient hearing. And I'll take this opportunity to invite all of you to DOS midterm conference, which we are planning to hold in Hotel Ashoka, New Delhi. And please block your dates, 2nd and 3rd September. Thank you once again.
Thank you, Dr. Bhalla. It's excellent talk. I always enjoy and I keep learning every time I listen to it.
Thank you.
I think
Thank you.
the detail he has gone into it, we can all take the message loud and clear that yes, we must upgrade our formula, because this is the single most important thing that is going to affect your outcome. And getting the right formula and the right biometry is very critical. Just one point I'd like to add is that we must do all these measurements before you do anything else on your patient.
Exactly.
That is, before you put any drops, before you do any applanation. So if your patient has already been dilated and if you have any doubt, it's good to call the patient back another day for the biometry. And you can always take, if you have differences, then you can always take it on 2 different instruments or validate your readings by doing it on 2 separate days. So that's the only message I'd like to give. Thank you so much. So we'll call upon the next person.
The next talk is on toric IOLs, tips and tricks. I invite Dr. Nitin to please deliver the talk.
Dr. Nitin Balakrishnan is a very popular and cataract and refractive surgeon. He has a very busy practice in Mumbai. Thank you, Dr. Nitin.
Thank you, Ritu, and for having me for this lovely IC. Toric IOLs are something which we all look forward to. In fact, the inclusion criteria for toric IOLs is now increasing with the increasing amount of accuracy which we get from these IOLs because of perfect planning. Many of the slides and points which I'm going to make in this particular talk may be a repetition of what Dr. Bhalla and Dr. Parul have already elucidated. So what are the critical factors for success with toric IOLs? A good patient selection, preoperative measurements, that is keratometry and biometry, IOL calculation and knowing one's SIA, and certain intraoperative factors which we will show. Now, in a patient selection, when we're doing a patient with the rule astigmatism, any patient with an astigmatism of more than 1 diopter, and against the rule astigmatism, any patient with an astigmatism of more than 0.6 diopters would be a good candidate for a toric IOL. Now, it's important, however, therefore, to confirm the amplitude of the cylinder, and the slides are getting cut. Slides थोड़े cut हो रहे हैं. Slides नीचे से cut हो रहे हैं. It is important to confirm the amplitude of the cylinder, and it's important that we use at least 2 methods to see that there is a sync between the 2 methods as far as the amplitude and the axis goes. Also, in cases where a refraction is possible before, see to it whether the cylinder on refraction is similar to the ones which are measured by the various instruments. Studying the holiday EKR map is a very, very important thing. If it's available, it should be done. Now, in an EKR map, the difference in the mean EKR 65 readings between a 2 to 4.5 millimeter zone of the pupillary size should be less than 1.2. The difference in the axis in this zone should be less than 10 degrees. And the histogram, that is the histogram as seen over here, should have either a single or a double peak and should not be a very skewed histogram. So this shows that this patient has a regularly irregular cornea, and therefore he's a good candidate for a toric IOL. On the other hand, if you see this EKR65 map, you see the amount of difference in the mean EKR65 reading between 2 to 4.5 millimeters. That's more than 1.2. The difference in the axis is more than 10 degrees. And if you see the skewing over here, it is skewed over a very, very wide zone. And therefore, this histogram map clearly shows that this patient is therefore not a good candidate for a toric IOL. And one shouldn't take him up for a toric IOL as far as possible. Now, there are various errors in measurements. Dr. Parul has already shown this. If the head is not sticking to the head bar before while during the measurements, if the head is sticking to the head bar but there is a tilt, and at the same time, in case of a normally positioned patient, see the amount of difference. The difference can be as much as 1 diopter in magnitude and almost 10 diopters in axis. And therefore, it's very important, like Dr. Parul mentioned, that your assistant or your optometrist be told how to take these readings and probably repeat the readings in case the differences are being seen. Coming to the toric IOL power calculation in the preoperative planning, we can either use the online calculators or you can use an image guided system depending on what is available. It's not necessary that everyone should use an image guided system. The online calculators, the most commonly and the most widely used calculator for a toric calculator is a Barrett online calculator. So this takes into consideration the posterior corneal curvature, it takes into consideration the ELP, and finally it gives you the toric model of the lens as well as the power of the lens. The advantage of the Barrett online calculator, like I mentioned, it takes into consideration the lens thickness and therefore the ELP is taken care of, and also takes into consideration the posterior corneal astigmatism, which normally ranges from 0.2 to 0.78. Now, if we ignore the PCA, what happens is you could get an overcorrection in a with the rule astigmatism and an undercorrection in the against the rule astigmatism. We also have online calculators from various companies depending on whichever lens you're using, which also are a good option available. Image guided systems are a very good tool if it's accessible to use for the preoperative planning. I have experience with the Varion. You have either the Varion or the Callisto. Again, here you can compare the various keratometries, all the keratometries which you have fed in from the other instruments, as well as the keratometry measured by the Varions, and you can either take the two closest matching keratometries, or you can take in the keratometry which is a median or an average of all the. You also can have a comparison of the different IOL formulae, and you can change the wound architecture, the size of the wound, the position of the wound, and thereby achieve a better result. Now, you can see in this particular video of a Varion planning, we are changing the position of the wound from a 0 to a superior incision, and see the residual astigmatism over here, how it is decreasing. We started off with a 0.18 of a residual cylinder, and if we do the incision, say somewhere about 90 to 95 degrees, we can reduce the astigmatism, the residual astigmatism, to almost 0 with the same model lens or the different model lens. Again, we can do this by changing the wound size. But the most important thing here to understand is one should know what is one's SIA, that is surgically induced astigmatism. The SIA varies depending upon the site of the wound and also varies depending upon the size of the wound. So we have to calculate our SIAs for different wound incision positions and different wound sizes. So a 2.2 or 2.8, if you're using both of these incisions, again a superior incision will have a different SIA from the temporal incision. Now, the basic requirements is just a sample size of about 30 to 50 cases. You can either do it on a Varion. Again, very important that the pre-operative and the post-operative keratometry should be measured on the same instrument so that there is no error in calculating the SIA. So you can either do it on a Varion, or you can do it by sending all this data to Dr. Warren Hill's website, where it automatically calculates your SIA, and this can be used for all your future calculations. Coming to the intraoperative considerations, the toric marking is something which is very important. You can either do a freehand marking using various markers available, making the position sit in a vertical position so that there is no cyclotorsion. Various markers are available, and I'm sure all of us have been using these. There is a slit lamp method of marking where the slit lamp beam is oriented to the 0-180 and a marking can be made with a pen. It's important to mention here that all markings, whether it is pre-op or intra-op, should be done with a very, very fine and a sharp tip pen, because if there's a smudge, there can be a difference of almost 4 to 5 degrees in the alignment of the lens. The third marking is obviously on the OT table. That is the final lens position marking. We can also have, since everyone has been using smartphones, we can also have various smartphone apps which are available today for getting the 0-180. That is, you have one from Dr. Saurav Patwardhan, you have a toric axis marking called Tor axis, or a Toricam axis which Dr. Graham Barrett has released on the App Store. Image guided systems are another good method where you get a markerless system, and from this markerless system one can align the lens to the right axis. So what are the three important steps in the toric alignment marking? First is a gross alignment, where you align the lens markings to almost 10 to 15 degrees of the intended position. You then remove the viscoelastic, and finally you do a final alignment and centration of the lens. So this particular video I'd just like to show, the lens has been placed inside. One second. We are now dialing the lens into position. I'll just speed this up in the interest of time. And as you can see, it's always a clockwise rotation which is to be done, especially for the C-loop IOLs. You keep dialing the lens until you are almost about 15 degrees from the intended position. Having done that, you go behind, get out all the viscoelastic from behind the lens, do an aspiration irrigation, remove the viscoelastic from in front of the lens, and then you would finally align the lens to the final position. Otherwise, what happens is when you already align the lens to the final position and you then start doing a viscoelastic removal, there can be a further rotation of the lens, and then to rotate it anti-clockwise could be a very, very difficult task. Toric IOLs and high myopes, it's very important to understand that patients with a large axial length, especially the ones above 25 millimeters, have a large bag, and there's poor peer-reviewed literature has proved there's pure toric IOL stability. So it's ideal in these cases to consider using a CTR to prevent the toric IOL from rotating after in the post-operative phase. Again, in a small pupil, sometimes it's very difficult to visualize the markings. And in these cases, what can be done is you can nudge the lens a little downward in the opposite direction to see whether the markings are in sync with the final toric axis marking. We have also developed a new instrument called as a duolator. This is the instrument which is a combination of a dialer and a Y-hook. So this can be used with the irrigation from one port. You can gently push the pupillary margin, check the alignment, and if it's not in sync, I'll take about a minute or so, you can dial it with the same instrument. You don't have to come back again and use another instrument to dial the lens into position. So what happens if you overshoot the intended axis? It's very important that once you overshoot the intended axis, do not try to rotate this lens in the anti-clockwise direction. You need to spend time. You need to again, as you can see here, we have overshot the final position, and it's important that you re-rotate the lens. You may have to spend time, you may have to do a 180 degrees rotation again, but it is always better to rotate it in the clockwise direction. End of the surgery, very important that you check that all the viscoelastic has been removed, because leaving viscoelastic in the bag can cause a post-operative rotation. And the final step after having injected the intracameral antibiotic is depress the lens downwards towards the posterior capsule while you are injecting maybe the saline to form the chamber, or when you are injecting the intracameral antibiotic. The depression of the lens helps in two things. It helps in pushing out all the BSS from behind the lens, and it helps the lens to adhere better to the posterior capsule without any interface. So these two steps are very important in preventing post-operative rotation of the lens. So the take-home message would be: use multiple instrumentation to confirm your measurements in the pre-operative planning. Include posterior corneal astigmatism by using an advanced calculator. Optimize your surgically induced astigmatism, and ensure a proper alignment of the IOL to the desired axis. Thank you.
Thank you so much, Dr. Nitin. That was really a very lucid presentation. Can I have a head count? How many of us are using torics regularly? So I think that's almost half the number of people here. And what's the reason for the others not using? Those of us who are not using it regularly, is it some fear? Is it lack of access to certain instrumentation? So, so now you've had a very clear, roadmap from Dr. Nitin. Okay. So it's good to try to analyze why did you have that refractive surprise. We'll be going into that much later. But I would just say that there's nothing to fear, because actually the best way to start your premium IOL practice is to start with torics. They give you very good results, and the worst comes to worst is that you'll have a little bit of undercorrection. As you know that every degree causes, I mean, if you don't get your axis right by say 30 degrees, then you could lose the toricity. But otherwise you're on very safe ground. So Dr. Nitin has given you a very clear way. I think you should start with torics. Do not fear anything more than 1.5 initially, diopters of astigmatism. Go straight for a toric. You'll have many more happy patients coming back to you.
And a better way of starting would be to start with a higher astigmatism. You start and see whether it is with the rule or against it. You start with the rule, then you have a better satisfied patient.
Yeah, Parul, you want to say something? Yeah, but Parul, I would just beg to differ from you. Even if you don't have access to an optical biometer, if you do it even on your manual keratometry, it's calibrated and you do it properly, and you do it on your auto ref also. If you have two readings in which, it's coinciding, you can be fairly sure of getting accurate readings. And as Dr. Parul already said, stabilizing your ocular surface is extremely important. Dry eye can be a big game changer in toric lenses. So it's very important to look whether your patients have dry eye.
One more thing is that you should analyze, is it because the axis that you planned and the axis that you have got, has there been some of the lenses rotate more? So, just try to analyze. Yeah, so I'm sure you'll. Right. I'm sure you'll do better now when you go back.
And initially, we have that nature, you're scared of even attending to the patient longer when you've done a premium IOL. So I think half of the people are scared of the dilate.
I think toric IOLs are very safe. You must start them. I'll call on Dr. Anita Sethi now. And Dr. Anita is the director and head of the Department of Ophthalmology at Fortis Gurgaon. She's a versatile surgeon, both anterior segment and oculoplasty, and she'll be talking to us about hitting the bull's eye with multifocal lenses. And after this, I would invite Dr. Aditya Kelkar. He would be giving his keynote address.
Thank you, Dr. Ritu, for inviting me to be a part of this really interesting IC. And, as Parul said, we've all struggled through all these problems. I have gone to conferences and gone from room to room only listening to toric to know why are my patients not doing well. So we've all been through it. It's nothing to worry about. So, and the previous speakers have all made my job pretty easy, because I'm basically going to take a lot of points from what they've said. And so is there a need for multifocal IOLs? Frankly, after becoming presbyopic myself, I hate my presbyopic glasses. I'm very good at counseling now because I really know what they're going to go through. We are getting cataract in younger patients due to diabetes, steroids, trauma. So leaving them with a plus 2.5 is really not a fair thing. And, there are longer active working lives. Who wants to see George Clooney and Robert Downey Jr. with glasses? So yes, cataract surgery is refractive surgery, and we really have to move with that. Are multifocals the panacea for this? We have to understand the limitations of these lenses. There is going to be loss of contrast no matter how much our lenses have evolved. There is still division of light. It is better bilateral, but we are still quite far from having the ideal replacement. And there are visual disturbances, halo, sunbursts, and glare. We even have still dysphotopsias even with monofocals. So these are all part of the lenses. EDOFs might answer some of these questions, and that Dr. Ritu is going to tell us later. So again, I'm going to just repeat what Dr. Parul said, that patient profile is the most important part when you're choosing your patients for a multifocal. The age, the personality, very important. Unilateral young patient with a cataract is always going to be a problem because you can never match the natural crystalline lens, but you do want to give them as little dependence on glasses as possible. In refractive errors, I find the hypermetropes are most accepting and forgiving, and maybe you should start your multifocal practice with hypermetropes. And the myopes, because they can see without their glasses, and when you tell them, if we give you a monofocal, you won't be able to see without your glasses, they just don't get it. But Dr. Saab, I can see without my glasses. Occupation, those who have nighttime driving, all of this, and affordability, all said and done, the more the patient has paid, the more he is going to expect from you. So you need to be able to put all these factors together. Frankly, I found that older ladies, who want to go for kitty parties, hypermetropes, they were my best place to start multifocals. So, we should all be kind to ourselves. I think more important than the indications are the contraindications to the multifocals. Fussy personality, the auntie who wants you to sterilize and sanitize every part of your OPD and yourself before you touch her, better not to touch her at all. Retinal disease, glaucoma, yes, these are definitely not, they have to be ruled out. And as Dr. Parul said, we must do an OCT in all our patients, and we must rule all of this out. And night driving is also an important, there are people who drive a lot, they are going to be bothered by these photic phenomena. So these are the contraindications, and I think it's just best to stay away from them. So I'm going to just illustrate with 61-year-old musician who used to teach my daughter keyboards and had moved to the US, lots of driving. Now as a musician, he needs his intermediate vision, and he'd been advised all the lenses in the US. And just to add, he had a unilateral hypermature cataract and no pressure. And he said, Dr. Saab, you decide. Now, these are really difficult decisions for you as a doctor because, yes, they have faith in you, but, you really can't, and they don't always understand when you tell them. So I gave him these two options. One is driving comfortably, no visual disturbance, but using a small reading number for near, which in my view is a correctable problem. Vis-a-vis reading comfortably without glasses, but some amount of visual disturbance while driving, which is an uncorrectable problem. And thankfully, he chose A, which I thought was also better for him, because it's better to have something you can correct. Don't promise no reading glasses. Tell them small reading glasses, but most of your work can be done. So it helps you choose the lens for the patient. Counsel the counselors. And actually for premium lenses, as Dr. Parul said, I counsel the patients myself. But also counsel the counselors because they like to go out and ask everybody in the OPD. We can only say a reduced dependence on glasses or an increased range of vision. We have to underpromise and overdeliver. We cannot promise the patients that they're going to, just because they spent more than $1 lakh, they're going to go back to vision of 25 years old. So I'm just going to highlight, Dr. Parul has already told all of this, but we must rule out subtle ERM, VMT, which sometimes are not visible to us anterior segment surgeons behind the cataract. The dry eye workup is so important. 6 N6 and Dr. Maza nahi aaya. It's just, you don't want to hear that. And we have to have a low threshold for toric. Dr. Nitin has really explained that very nicely. And I have myself 0.5, 0.6 to 0.75 against the rule. That's my limit for multifocals. Wherever possible, get it done on 2 instruments. Please take into account the posterior corneal astigmatism. And I've been using immersion for a really long time, and it is as good as optical, but if I have a doubt, I'm going to send it to my good friend, Dr. Parul. And yes, if there's a doubt, and do the keratometry, different places, different people, just don't go in for a multifocal with a doubt in your mind. The next difficult question is which lens and which power. You do need to discuss the pros and cons of all the lenses. I've included EDOF here. It's not a multifocal, but sometimes it's just the better option, and it's part of your counseling. You really have to have a reliable biometry. Now, choosing the power of the lens, again, I choose it myself. I don't let the optometrists do this. And you have to see whether you want to take emmetropic power or the first myopic 0.2. And some of the multifocals have a very small landing zone. And actually, they advise you take the first hypermetropic, the first plus 0.1, 0.2. So it depends on your lens. And I discuss with the company people as well. I'm very particular about the biometry. I find Barrett's 2 is an excellent formula, and the ASCRS for post-refractive surgeries is again a very good formula to use. So as already been said in the toric, first get comfortable with the monofocal toric. Once you're comfortable with it, you figured out how it works for you. It takes some time, nothing to worry about. We'll all get there, yeah. And make sure there's no rotation, incision on axis using flax. And then I always give a gap between the second eye. Sometimes you can make little mini corrections in the second eye. If your biometry has been a little off, if you feel that the patient is not doing as well for near, you can go a little plus. There are some lenses actually which are for the mini well lenses distance and different one for near. Earlier, Restore used to have different ads. So you can do a mini correction in the second eye, and we all know the multifocals will work best bilaterally, and we must always tell our patients that there is going to be some adjustment, and then when it's bilateral, it's going to get better. So this choice of IOL and choice of patient, the doctor should definitely, surgeon should be very much there. So in the surgical steps, there's nothing very much different other than you must know your SIA. Tend to make a smaller axis because you really don't want it to go out. It has to be well centered. And I would just add to what Dr. Nitin said about removal of visco. When I do my last removal of visco, I do the last positioning under irrigation. I use a dumbbell dialer. So yes, be about 10 to 15 degrees away. And then just when you think most of it is all out, the last rotation I'll do under irrigation and do it with a dumbbell dialer, and then just leave it in position. Now, what do we do when there are refractive surprises? So this was a post-LASIK myope, and again, we emphasize we must ask the patient for previous refractive surgery. This lady had refractive surgery only on one eye and had omitted to mention it because it was 25 years ago. She thought it's not relevant. And so as soon as I put the lens in and I told her that, oh no, you were so cooperative. She says, yeah, I've already had surgery before, so I'm going to be cooperative. So I just nearly died over there. And I raced out. Now I've done the surgery and we did the calculation, and we found that we've put in 21.5 instead of 22.5. I said, okay, let's wait and watch. I didn't want to take it out for just one diopter. And the next day, patient was 612 N12, but happy because we had never promised her that you will be not, how you're going to be just a few seconds more. But her eventual refraction, and I waited for the other eye for a bit, she actually was with a plus 0.5 cylinder, 6 parts, and quite happy to use a plus 1.25 add. So this is a forgiving lens with a good defocus curve. I mean, there's a good landing zone. So this, you should know for each lens which has a better landing zone. And again, you should have a good friend. If you don't do LASIK or PRK yourself, you should have a good friend whom you can offer that option. And I found in the few patients where I do have a little bit of cylindrical for whatever reason or some little refractive error, when I offer them that, they say, no, actually, we're fine. The other eye is compensating. So mostly they're fine. And most people are not that fussed if they have to wear a little bit of glasses. So, but we should be able to just offer that to them. So I think if we are looking carefully, choosing our patient carefully, listening to the needs of the patient, trying to put everything the way the patient, what the patient needs, and telling them what to expect, and what we can't do. Astigmatism, very, very important. So first get the torics right and then go for multifocals. Multifocal toric, as I said, I have a very low, very quickly I will put in a toric because it really affects the outcome. Biometry, again, very carefully. And again, cost, this is more for us in the corporate hospitals where nothing gets covered. I mean, these multifocals don't get covered, and patients just insist that we want everything covered. So we need to have that discussion before and not have any problems after the surgery. So I think armed with this, we can all get ready and shoot and get a perfectly happy patient and surgeon. Thank you.
Thank you, Dr. Anita. So how many of us are using multifocal IOLs here regularly? Yeah, I think quite a few of us. So I think if there are any problems that you're facing in your patients, we can take the questions later. Just a small size that, we people, because we have dark irises, smaller pupils, so the glare issues and all are a little less. I think it's overrated what the companies and what the, because most of these studies are done from, people with lighter irises. So in our Indian population, it's not so much of an issue.
But the
Yeah.
patients read up and come, and the moment you say multifocal, they think that actually you're talking either about a progressive lens or you're talking and, glare
Yeah,
hoga.
obviously, if your patient is not happy with progressives, then he's not going to be a good candidate for multifocals. Yeah, thank you, Dr. Anita. And now I'd like to invite, it's our pleasure to have Dr. Aditya Kelkar here. He's director of NIO Pune, and he'll be talking to us about the real world outcome with extended vision IOLs in an Indian population.
Thank you, Dr. Ritu, for this kind introduction, and thank you, organizers, for having my talk here. So I'll be talking about my experience of using this VVT IOL. As you may be knowing, I do a lot of retinal surgery work as well. So it so happens that probably it's now in my blood to under promise and over deliver. So probably that's why one of the reasons why I find this lens extremely useful as well as very satisfying for the patients. So what patients exactly want is that they want to drive without any glare and halos. They want to have a good time while watching the TV. At the same time, watching their looking at their phones, or when they go shopping, they don't want to depend on the glasses to do their day-to-day activities. So these are the basic requirements for any patient who would be suitable for a EDOF lens, and which, in my opinion, is probably each and every patient probably has these requirements nowadays, because reading as such has reduced quite a bit compared to how people in the past they used to read. Now everybody's on the phone most of the times. So how far we have come? Initially there was monofocal, and the dependency on glasses was the question, and so people moved on to multifocal lenses, and then there were issues with the halos and glare, and then came the EDOF to find a solution, something which is better than multifocal. So talking about EDOF, there are different types of EDOF lenses and different technologies being used. One of the common technologies is obviously the small pupil aperture EDOF lens, but it's a lens that has a very simple principle like pinhole effect, but at the same time it's more light dependent. So if the light is reduced, these patients can suffer from difficulty in low light conditions. Then came the Symphony lens, or the EDOF lens, which was based on diffractive echelette design, which kind of stretched the wavefront, and in order to achieve the multifocality gives rise to some kind of halos and glare, even though it has fairly good spectacular independence that you can achieve with this lens. And because of the halos and glare being still an issue with the extended depth of focus lens, then came a novel idea from Alcon about the VVT lens, which uses the proprietary X-wave technology. So it has so how it exactly is different from the monofocal intraocular lens is basically it stretches and shifts the wavefront compared to how the diffractive multifocals use the principle of having multiple foci using diffractive or refractive technology, and that's why the halos and glare is much less compared to the other lenses. So if you happen to use this lens for the first time, when I used this lens for the first time, I was dialing the lens in the bag and tried to rotate it to the axis that I wanted, because this was a toric lens that I was using, and I thought it's exactly the same as the accuracy of IOL. So I looked at my assistant to confirm that this is exactly the VVT lens that I am using, because it has a very subtle bump in the center which may not easily be picked up in the initial few cases. Then I saw in detail after tilting the eyeball a little bit, then you see a small impression of this central halo. So what it does is that there is a small elevated plateau about 1 micron that stretches the wavefront, and then there is a 2.2 millimeter region in the center that kind of shifts the wavefront to utilize all the available light energy. So without compromising on the amount of light that enters the eye, this wavefront is stretched, and so we get a seamless vision without much dependency on the glasses. So that's the principle of this intraocular lens. So stretch and shift, but it does not split the wavefronts, and that's why the glare and halos are much less compared to the other types of EDOF lenses. So the difference between the different variety of lenses, the monofocal lens, the trifocal lens, and the EDOF lens, that's where exactly the EDOF lens with VVT currently lies. So it has better vision experiences, but less amount of halos and glare, as well as the quality of vision can be comparable to the monofocal vision. So the patients who have difficulty, already are driving at night, do not want any halos or glare, and more dependent on computer related technology for their work related work issues, are the best candidates for this type of IOL. So somebody who's in their 50s or 55-year-old and who is currently working in a, say, IT industry, would want to use the computers most of the day and probably travel back at night for driving about 10 to 15 kilometers in his car, might find this lens much more suitable compared to a multifocal intraocular lens, which can have halos as well as glare in many of the patients. So coming to the near vision acuity compared to the multifocal IOLs, yes, it has a slight compromise on near vision when it comes to fine reading. But again, as I said, the number of hours that you spend reading fine print nowadays is much less than probably in the older days. So the successful integration is possible only after you have understood the criteria of selecting these patients. So obviously, age and relative presbyopia, pre-existing refractive error, ocular conditions, corneal refractive surgery, personality types, the visual needs, profession, lifestyle, the status of the current lens, and the type of visual compromise, and the surgically associated risks are the criteria that you need to consider before implanting this lens. At the same time, at the moment, I do not encourage the patients who have a severe dry eye or those who have other pathologies like macular degeneration or corneal pathology or uveitis to go for these type of lenses. Right. So the A constant that we use for the optical biometry is 119.2. That is something that you need to take into account. And also the results that we have got by now is we have an experience of more than 200 lenses that we have used so far. And we conducted a study of 140 eyes with 70 subjects who finished 6 months follow-up. It's a retrospective study. All the patients achieved good intermediate as well as distance vision, and we were quite surprised with their near vision abilities, and almost 40% of the patients were comfortable without glasses for all the near work. 10% required only plus 0.75 when they wanted to do fine work, and about 1 diopter in about 27% of the patients. So roughly, if you see, approximately 75% of the patients are relatively free of glasses when it comes to even the near work, whereas 13 to about 25% of the patients required 1 to 1.5 diopters of correction for near work. The limitations for this technology are the bump that it has in the center. In patients who have a very small pupil, may experience slight myopic shift. So you have to see how the first eye is behaving and then probably plan the other eye after you have ensured that the refraction in the first eye is bang on. So with that, I once again thank the organizers and Dr. Ritu for having me here. Thank you.
Thank you, Dr. Aditya. That was really nice. I've had some experience with Vivity. How do you plan your post-op target refraction?
Yes, so what we do is target emetropia for distance vision when we do the first lens. And if the patient achieves good distance vision, then only we go for slight undercorrection for the other eye. That way you can have more independence from glasses. But
Slightly,
since
you
these,
mean on the myopic side?
I go a step down. So for example, if the patient's IOL power is say, let's say 22, I would rather prefer slightly lesser power, which is towards myopic side. The first myopic power than 0.
Right.
Can I, Doctor?
Yes,
you said you're a retina specialist, and you said that you don't. I mean, it's an exclusion criteria. All retinal disease, or
no, the patients, for example, who have got wet AMD, they are likely to have anyway poor vision. So these expensive lenses, I wouldn't really encourage them to have. But somebody who has drusen, I would still go ahead with it.
yeah, because I mean, since there's no distribution of light, and we're not going to affect the contrast sensitivity, I see no reason why we shouldn't put
but
it in
suppose the
mild.
patient has
Yeah,
say,
of course.
corneal scarring,
Yeah.
there is a chance that he may have additional halos and glare with this lens.
No, these are quite forgiving
yeah, very
lenses, and if
forgiving,
your
yeah.
biometry is a little bit way off, also target,
Yeah, they do well.
patients can still have. The only thing is the distance vision may be slightly less than what you would get with a monofocal. So there's always a trade-off in all these lenses between, you know, your range of vision and, of course, the
Yeah.
focus.
So all said and done, I think this lens is really good when it comes to when you want to counsel the patient. For example, when you talk about multifocal lenses, what patients expect is definite freedom from glasses. Whereas in these lenses, you are already telling them that you are likely to require slight reading glasses, and they are happy to accept it post-operatively. So as such, as you said rightly, it's more forgiving because it actually under-promises and over-delivers.
Yeah, at the same time, you know, if you counsel them preoperatively that for reading, just use a little bit more bright light. That often helps them to read much
That's
better.
right.
Yeah.
So what I feel is that these modern monofocal intraocular lenses that were introduced before this VVT lens, they probably overpromised the intermediate vision. They are as good as monofocals in my opinion, whereas this one is very close to multifocals when it comes to spectacle independence and very high on patient satisfaction because the halos and glare are much less.
Absolutely. Very safe to go to. So if you're going to start off your multifocal practice, then best is to start off with EDOF IOLs.
Yeah, and Dr.
Thanks.
Ritu is now going
Thank you.
to tell us more about how to adapt your EDOF IOL in your practice. Dr. Ritu, as everybody knows, is a very prolific cataract surgeon and runs her own successful practice in Noida.
So good afternoon, everyone, and we'll be now talking a little bit more about EDOF IOLs, just to take it a little further from what Dr. Aditya has already said. And as we know, you know, we are doing cataract surgery. It's no longer just removing the cataract. It is a refractive surgery. We can't escape that. And there's always a gap between what we think the patients want, but actually we are all on the same page. The doctors and patients are on the same page. The patient doesn't really know what he wants. He just wants to see well at all distances. And he'll come to you saying that he wants to reduce dependency on glasses because his neighbor doesn't wear glasses. And there are very few patients who actually say, I do want to continue wearing glasses even after surgery. But there are that 1% who do want. And what do we doctors want? We want our happy patients. We want that they should have good uncorrected distance, uncorrected near and intermediate vision. Patients should not come to us complaining of dysphotopsias. They should have a good contrast sensitivity. And they should keep referring more patients to us. And they'll do that only when they are happy with their results. So the multifocal presbyopia correcting IOLs have given us very good vision at distinct distances, good functional vision. But the problem is that there's always a compromise between the range of vision, the loss of contrast, the halo and glares. So we've been looking for an IOL which offers us the best of everything with a range of vision, minimal photic phenomenon, and high patient satisfaction. We know these optic principles about how monofocals work and how you get, a blur if you're looking at anything near or intermediate. Multifocality has also been spoken about by Dr. Anita, so I won't go into it. But the EDOF lenses, basically, they work on an elongated focus rather than discrete foci. They have an elongated focus, and so they give a more natural vision. So the aim is that you get a sharp, good image over a continuous range of distance. So you overlapping images that you get in multifocal lenses are avoided, and so the halo and glares is less. And this also avoids the secondary out of focus image, because basically in multifocality you have 2 or 3 images being formed, but there's a distance between the image, but the other image is always there. So the image quality is always at the expense of depth of field. I'm repeating this again and again. So how do you define this? It was seen actually that many of our monofocal lens patients, you find they are able to see near vision. How does that happen? Because they have a certain amount of pseudo accommodation. And this was seen, and this was actually inversely proportional to the pupillary diameter. So if you have small pupils, even monofocal patients are able to read well. And so the American National Standard Institute, they said that an EDOF IOL is an implant that provides an increased depth of focus compared to a monofocal IOL, with a superiority when it comes to the photopic intermediate vision, and it's non-inferior for distance vision. And the American Academy of Ophthalmology Task Force said that there should be within a one-line best corrected vision of a monofocal. And they should have a 0.5 diopter more of defocus as compared to a monofocal. And at least 50% patients should have better than 20/30 vision. Now, these are not a single kind of lens, EDOF lenses. Actually, they are, a wide basket of lenses. And the pure EDOF IOLs are those who are either spherical aberration based, or they're based on the pinhole effect. And most of what we call EDOF IOLs are now hybrid multifocal lenses. So the pure EDOF, as Dr. Aditya also said, is pinhole. Unfortunately, we don't have these lenses available in India, but they can be extremely good for post-keratoplasty patients or keratoconus patients where you have very, asymmetric corneas. So the pinhole effect can be very good in such cases. Then you have the spherical aberration EDOF IOLs. We have the Mini-Well from SIFI that is available. And basically, it's based on having positive and spherical. It plays with the positive and spherical aberrations. As we know, light, when it is getting refracted through, you have a positive aberration and a negative spherical aberration that can be created. And these lenses, they are based on that. So they give an extended depth of focus. These are hydrophilic lenses, work fairly well. I don't have too much of experience with them though. Then you have the enhanced monofocal lens, which came from Technis iHands lens. Again, it's based on a spherical aberration. It's basically a monofocal, giving a very little bit more of intermediate vision. But if you do a micro mono vision with these kind of lenses, they do work well. And again, it doesn't come at any negative, there's no side effects. So it's a very safe lens to use. So it's just like implanting a monofocal. So I'll skip the video. Then I've also been using the magnificent EDOF IOL from the Care Group. Again, it's a hydrophobic lens and it works like the iHands. So again, where your patient has less affordability, you can still offer them a very good result with these lenses. Then coming to the hybrid lenses, the Swiss EDOF lens, the Lucidus lens, again is a very nice lens to use, very safe. It's basically, it has a pseudo non-diffractive beam in the center, and this gives an extended depth of focus lens. It's like a plate haptic lens. It is a closed loop lens though, and these lenses center very well, and patient satisfaction with these lenses is very good. Of course, some patients do complain of a little bit of waxy vision at times, but generally they are happy. Again, from our Appa Swami, they have the Superphobe in focus lens, which is also a hybrid refractive lens. and it has a small central zone for near vision. Again, it is independent of the pupil because it's a small zone. So if you have a reasonably sized pupil, these lenses work well. And the Symphony, actually, which is a diffractive EDOF IOL, was the first one from FDA to be approved, and we've all had vast experience. But again, these lenses are not without the halos and glares, although it's much less. But patients can have these, and the advantage is the achromatic diffractive posterior surface. So that gives a the chromatic aberrations are much reduced. The AT Lara from Carl Zeiss, again, it's a plate haptic lens, and it is, again, it does have diffractive rings, 15 of them. So although these are considered EDOF, they're actually multifocal lenses which give you good distance and intermediate and a little bit of near vision. Now the Technis Synergy is actually a combination of a bifocal with an EDOF lens. Again, it gives very good vision at different distances, but again, it is a diffractive lens, so it does come with a little bit of a glare and halos, though it's much reduced as compared to the bifocal lenses. Alcon Vivity, I will not talk much as Dr. Aditya has already told us about it. But again, I would say it's a pupil independent lens, minimal glares and halos, and patient satisfaction with these lenses is good. You can use it even in patients who have glaucoma, where you would not like to use multifocals, or patients who have ERM without macular edema. So your patient selection can become much wider. So why is the need for EDOF? Basically, we all trying to move towards presbyopia correction. And the new design concept is not to absolutely eliminate spectacle dependence, but to reduce it. And intermediate vision has now become so more important for us for our daily activities. And so we have a much more natural range of vision, fewer gaps, reduced photic phenomenon. And these are much more forgiving if you have any residual refractive errors. So in conclusion, we must, I think, try to see what all the lenses are available to us. What are the benefits? What are the downsides? Nothing can be as perfect as the human eye. And understand each lens that you're going to deal with. What are the pros and cons? Tailor it to your patient. And try to do some mix and match or micro monovision if you find that the first lens is not working well for your patient. Counsel them for neuroadaptation, and do a proper counseling to avoid any misunderstandings and over expectations. Thank you.
Thank you, Dr. Ritu. That was an excellent description of all the EDOFs available. So let's ask you, what is your EDOF of choice?
Well, I've been using the Vivity a lot, but it's again an expensive lens, so I don't think everyone can go for it.
And if cost is not put out?
Yeah, if cost is not there, I think as EDOF, I would go for Vivity.
And how many here are using EDOF? Yeah, well, mostly everybody. Yeah. So are all the lenses included in what she said, or were there some more that people are using? Just.
Yeah, as I mentioned, the Magnificent, and I think even Biotech has come out with an EDOF, and Appa's
the
also
upper one
out.
is also quite good.
But Magnificent is a hydrophobic one and works really very well. And patients almost innate, they do have. Yeah. Anyone else has a good experience with the Magnificent here? Yeah.
Upper in focus. Not very widely used, but I do have one patient who's quite happy.
Even Rayner has come out with the extended monovision. Anyone has used it? I haven't had much experience with that. Yeah.
I don't find the iHands as a very good. All my patients have 2.25, so I'm not happy with the iHands. So.
And any astigmatism more than 0.75, it doesn't work.
I agree.
Then the intermediate is not an add-on. It just
Yeah, but
because they understood the limitations. So till now, but see, that's what company sells to you. They never told you.
yeah.
In clear words, till we started speaking on forums that any astigmatism more than 0.5, 0.75, I7 doesn't give you interference.
Yeah.
That's the reason that now they have incorporated for it. So you have to be very careful, keep talking to your colleagues, and I always go to people who have started using those lenses for a few months and then I ask them their experience.
Yeah.
I think whether it's EDOF or multifocal, any toric, I think more than 0.75, you need to correct it. whichever way you do it, whether it is by doing any LRIs or doing a toric or adjusting, as you said, on your varion, you need to do adjustments, because any residual astigmatism is it degrades the vision quality. Thank
Yes,
you.
and now we'll learn more about that kind of patient. Dr. Reshma will now speak about pitfalls in premium IOLs and handling the unhappy patient. Dr. Reshma is a prolific cataract surgeon from Mumbai, and we look forward to hearing what she has to say.
Hello, everyone. And I don't know, best for the last, should I say that? But everybody has been talking so much about these premium IOLs. I think this will be pretty much a recap of the all the discussions that I've had earlier. So why premium IOLs now? It's more like a necessity. I think we all sit in our clinic and we have patients who have higher expectations. It's become a refractive procedure, and so what all we need to keep in mind is that now with the entire evolution of the biometry, amazing new formulas have come in, and the IOLs are also available that correct presbyopia. Hence, even the expectation from the patient and as well as from us to deliver to the patient has become very high. So as Albert Einstein said that if I had an hour to solve a problem, I'd spend 55 minutes thinking about the problem and 5 minutes thinking about the solution. So what it means more is that when we have a patient who's sitting and who's for a premium IOL, we need to do our homework extremely well. We have to first think in our mind, what is this patient's expectations? Patient selection is extremely important, because just an over expecting patient who comes with say a patient sits and even he's bothered about the little bit of cataract that, and he just talks a lot more about that small cataract that he has. That these kind of patients are extremely picky, so we have to select the patient discreetly. Pre-op counseling, as Dr. Parul and a lot of our other speakers have already mentioned, of course counseling is very, very important. Surgical planning, peri-op management, and management of expectations, I think that's very, very, very important. So what do we do as a homework for ourselves? Refraction test both the eyes. There are times when we've heard just that when the patient comes in and the right eye surgery, then you just do about the right eye. No, just test both the eyes properly. Test vision at all distances and develop a rapport with your patient. Help to know the patient's range of requirement, because every patient has a different range for reading and intermediate. So when I do a refraction of a patient and I see that, okay, where are you really holding your newspaper? Have you ever asked that to your patient? Where are you comfortable? Because a lot of patients who we feel are holding at 33 centimeters, but they say, no, I'm not comfortable here. I always put at 40 centimeters. So that's where we have to understand the range of where the patient really wants it and make it customized accordingly. On table, in the OPD, we have to see the slit lamp, see for the tear film, assess the tear film and ocular surface, the T-bar time, the Schomers. If the tear film is suboptimal, there may be an issue related to the tear volume or tear quality. Meibomian gland analysis, very important. Rapid T-bar can be due to MGD. A thick MG secretion can result in suboptimal vision and unhappy patient. So even after doing a fantastic surgery, even after putting the lens properly, yet the patient is unhappy, this is something we have to go back and think that, is this the issue that the patient is facing? The endothelium, we have to look at the guttatas, see if that is the cause of the poor vision. The pupil size, centration, angle kappa, we all know about it. Pupil size is most important, because if there's an unhappy multifocal lens patient, a photopic pupil size should be close to 3 millimeter, whereas a scotopic ideally should be 5 to 6 millimeters. Before doing the surgery, we have to look at the corneal topography, as Dr. Nitin has already talked about. Tall EKR, a peak, a good K-metry spread, regular overall. Look for the white to white. Make sure there are no Fuchs dystrophy or any other corneal endothelial issues, and astigmatism. Of course, we know it's extremely important, and most cases are related to residual cylinder causing the patient to be unhappy. The macula has to be checked very discreetly. Do an OCT in all patients. Do not miss on any subclinical ERM or aneurysms. Diabetic ARMD cases are best to be avoided. So, what are the main things that we have to look in? Why would a patient be unhappy even after putting the best lens, even after doing a fantastic surgery? So, these are all the red flag things. A very high demanding patient who wears glasses, even for low refractive errors, all the time. You know, these kind of patients are very, very highly demanding, and hence, this is one of the very important selection criteria that you really want to go in for a multifocal lens for that patient. Particularly animated in describing every detail of his or her cataract visual disability. The patient obviously with a severe dry eyes, now that has become important criteria to check before going ahead with a multifocal lens. Evaluate for any high order aberrations, angle kappa, astigmatism, inaccurate biometry. Barrett Universal has to be used for all patients that we go in for a multifocal. Refine your nomograms for cylindrical correction and markings. So a patient who's already got a surgery done and he comes and he's really unhappy even after that, there could be a negative there could be a negative or positive or a dysphotopsia, and in such cases we have to look in carefully, and if required a YAG laser should be done for this patient to release that. Or also if there is you have to check if there is any IOL decentration, and if there is a PCO, of course get a patient would be unhappy even after doing a multifocal. You have to look in for other factors, like you've done everything, but why is the patient still unhappy? So identify the ideal multifocal lens, rule out all the red flags. Advanced technology for pre-op planning are available. Please use them. Close the loop by tracking results and modifying pre-op process accordingly. Logical stepwise approach helps to frame the problems and take the right step towards solution. And small subset of patients may need exchange, but this too can be avoided by meticulous pre-op homework. Now this is just quickly showing some of the patients. This patient that we has been done on anterior readings, and we look at what is the final biometric reading that we are planning to put in for the patient. So if this is showing say 11 diopter for the patient to be given for premium IOL, and check properly on pentacam as well, do all proper readings from couple of different machines so that we are finally sure. So even that was also done, the patient was also done IOL master, and here in both that we find that the we're getting the same results is when we finally go ahead doing the putting in that kind of lens. So what I'm trying to explain here is that don't just go by the results from one. If you are not sure, go in for multiple different formulas and finally decide which lens we want to insert in. In case of toric calculations also, it's important to get the so there is in the toric calculation basically when we use lenses, it is we have to see the ACDs, and the ACD depth is very important. And if we look into details about every aspect of it, we eventually get a happy patient. So ACD plays an important role in effective lens position prediction and cylinder power exerted at the corneal plane. As per studies, it is shown that in eyes with deep ACD, a given toric IOL will correct a lower amount of corneal cylinder than in one with the normal eye ACD. And conversely, for a hyperopic eye, the same IOL will correct a higher amount of corneal cylinder. So this is a hyperopic patient. Now if there are two different formulae, two different toric powers, which one should we choose? So if you can see in the left eye, the ACD was not used as one of the components. It was showing as a 25, and otherwise it is a T3. So it changes if you put the formula with the ACD, it gives us a more accurate result. Posterior corneal astigmatism. So in previous calculations, assume anterior and posterior corneal curvatures have a constant ratio. Many studies have found that posterior corneal curvatures vary wildly among individual patients. Ignoring posterior corneal astigmatism may yield incorrect estimation of total corneal astigmatism. This has already been covered earlier with earlier speakers, but I will quickly give a recap that increasing age and the posterior corneal astigmatism has a correlation. So affects astigmatism of the anterior more than posterior corneal astigmatism. By increasing age, the step meridian of the anterior corneal surface tends to change in direction from vertical to horizontal. The posterior corneal astigmatism will compensate the anterior corneal astigmatism in younger population and increase the total corneal astigmatism in older population. The anterior corneal surface, which is in contact with air, has a positive refractive power, whereas the posterior corneal surface in contact with the aqueous has a negative. Hence, a vertically aligned steep meridian on the posterior corneal surface generates an against the rule rather than with the rule astigmatism. The average power of posterior corneal astigmatism is about half diopter, and this value should be added to the anterior against the rule astigmatism and subtracted from the anterior WTR astigmatism to determine the total corneal astigmatism. If the meridians of the anterior and posterior corneal astigmatism are same, posterior corneal astigmatism reduces the anterior corneal astigmatism, whereas if they are 90 degrees apart, then it increases. So this is just a quick surgery that just 1 more minute remaining, ma'am. So here to show that it is very important in toric lenses, Dr. Ballard had put up this point that when the lens is introduced inside, very important for toric lenses is when we are aligning the lens, it has to be first put about 10 to 15 diopters away, and then a very thorough wash removing all the viscoelastics, not only from above the lens but also from below the lens. It's important to tap the lens so all the viscoelastic is removed and a clear and everything should be cleared, and then aligned it to the exact position. So in conclusion, the pre-op exam and counseling and calculation is a very important surgical process. As I said, what all we need to do to prevent any mishaps, and post-op looking at the results. Thank you so much.
Thank you, Dr. Reshma, for beautifully summarizing how to avoid the unhappy patient.
Correct.
Yeah, I'll just like to say a point that your surgery has to be really perfect with multifocals, and one important point is your centration. Now, if you're doing your patient under topical, it's very easy. You ask the patient to look into the microscope light, and your Purkinje 1 and 4 images should come close to each other. Because if your IOL is not well centered, then it's really going to lead to a lot of dysphotopsias post-operatively. Secondly, if you have any kind of a complication, a zonular dialysis, put in a CTR. Don't leave it just like that and put in a multifocal lens. Or if you have a PC rent, then you need to really reassess. Do you want to put a multifocal? If you think you can get a stable multifocal by, say, doing an optic capture, you can do it, but you also know that even that slight difference in positioning of your multifocal IOL can lead to a post-op result. So such patients can be counseled that they may need to have a top-up like a PRK or a LASIK post-operatively. And whether you want to do it complementary or the patient pays for it is a different matter, but you can counsel the patients immediately so that they're not disappointed and unhappy with the results.
Thank you.
Unhappy situations where patients are unhappy after trifocals or EDO has also got to do with some patients having dry eye. That's a very important thing in post-trifolic IOS, because diopter is the first refractive surface. So you may have a patient 6'6", 6'6", but not so happy, and that's simply because he's having dry eye. You put him on mitigating drops and it will run. Two, in toric surprises, when we dilate, we look at the axis. We did not discuss about how to fix the toric axis. So there are online, there is a site called astigmatismfix.com, and even in ACRS you have an online tool calculator. So if your toric IOL is off, you put the pre-op readings, post-op reading, your pre-planned axis and your post-axis which you have, which you've seen on the slit lamp, and it will tell you exactly how to proceed and what to do. I thought I'd just add that.
Thank you. Yes, Nitin. Can we have the microscope, the microphone?
I think it's very important in all cases of multifocal IOLs also to check the angle alpha and the angle kappa, because angle alpha more than 0.5 in preoperative biometries, I think this patient is going to be a bad patient for a multifocal IOL. So it's better to avoid those patients than to burn your fingers.
Yeah, but
later.
unfortunately, Nitin, how many of us have access to the iTrace? Because angle alpha is not available.
You
It
can
doesn't.
get it on the IOL mask on optical
No, you get angle
biometers.
kappa and that. You don't get
kappa,
angle
but
alpha.
then you can extrapolate it, and there are ways of actually calculating. It's
Really?
a mathematical formula.
Okay.
You can extrapolate it from your angle kappa.
Right. Yeah.
CME is English. Earlier we were talking CME, third macular edema.
No. No, not at all. Not at all. It's only, I mean, it depends on how clean a surgery you're doing, or if your patient is diabetic, then the chances of post-op CME, or if you have any complication, PC rent or something. But of course, these patients are premium patients, so you're definitely going to put them on some NSAIDs a couple of days before. So
Also
you need to optimize everything.
Also a pre-op OCT in cases of all patients with multifocal IOL, because you may have a juxtafoveal telangiectasia or something, and this patient which you may have missed a normal fundus examination or a thin ERM, which can
How many of us have a pre-op package for our multifocal patients? So include your optical biometry, your pentacam, your OCT, all part of it.
Yeah, should be done.
Actually, for all patients, they go through the same thing because you cannot predict.
Meenakshi, you're working in an institutional setup with everything available, but we have to charge our patients for all of that.
We have to charge our patients as much. It works the same way whether you are in an institution or in a...
Ideally, yes. Yes.
Ritu has one more talk. Yeah, so there's Ritu is just giving us an logarithmic approach to premium IOLs. And any other questions while she's, yes.
Just a basic question. While doing the immersion scan, the company people had told that even the LED light affects the axial lens sometimes. Does it really happen or not that?
No. I don't do it myself, but I don't think it's made such a difference to our outcomes. Yeah.
Other than asking the patient to just look straight ahead, we need to give them a light target or nothing.
If some of the patients are moving and are not so cooperative, yes, you give them a target. But usually if you tell them to look up, and mostly patients can manage, of course, you give Paracane and explain what you're doing. I don't think uncooperative patients are always there, and so then I don't think so, no.
Doctor, this is a very hypothetical question, but has it ever happened that any of the retina surgeons had to operate on a patient with multifocal IOL, and does it make their surgery difficult?
Apparently, it doesn't make their surgery difficult. I don't think any retinal surgeons left here now, but apparently it doesn't make. But if you know that the patient may develop some kind of retinal pathology like a diabetic, or you might want to avoid putting a multifocal if you think that they're going forward that they may. Having said that, I have many diabetics also who have no retinopathy, and we've put multifocal and they're quite happy with it.
So just to make some conclusions, I'll be talking about my algorithmic approach to premium IOLs. And we've already discussed that, we've moved from, we need to move on from monofocal lenses actually. And not that anything to detract from them, but yes, we need to offer our patients more physiological vision. And we've now realized that there's so many choices that it's confusing for us. What about the patients when we are trying to counsel them? At the end of the day, if you give them too many choices, the patient is not going to stick with you. He's going to go to the next doctor who just tells them, do this. So patients want to be guided. There are those who, of course, do a lot of Google and all, and they'll say, ki, Doctor Saab, mere to ye wala lens dalo. They'll come to you having done all their homework. So, you can go with their choice, or you may suggest to them something better. But I think giving them too many choices is not a good idea. So the key to success we've already spoken about is the patient selection, counseling, workup, selection of the IOL, proper surgical technique, and the post-op management. Of course, we didn't have much time to discuss that. You must find out the near vision task. So this is very important, that you should do a proper triaging, your history taking. I don't depend on what my optoms ask. I ask all the leading questions myself. What are your hobbies? It also helps you to create a rapport with your patient. When you ask them, what do you like to do? Do you watch TV? Do you play golf? You need to know what are their day-to-day tasks. Only then you can give them the right advice of which lens to go for. So you have to know, are they avid readers, or they don't look at a book at all, they only look at their WhatsApp, or I mean they are very fond of long drives. So you must find out about the patient's visual needs. Only then you will decide on what is their visual target, what is their target, is it, what kind of lens do they want. So all counseling and everything has been spoken about. Only a few words, that you should have a trained counselor, you should have a separate counseling room with adequate number of brochures, videos and all, so that the patient can understand things better and nothing is left as a surprise to him. So some patients say, oh, but you never told me this, I didn't realize, or they understand if they're going for a premium lens, they're never going to need glasses. So counseling is important, and when not to advise, even if the patient wants a multifocal lens, there may be times when you tell them, no, you cannot have a multifocal lens. So I think Dr. Neeta and Dr. Parul have already spoken much about it. And if you do have a complication during surgery, don't force yourself to put a multifocal. Better not to burn your fingers. So having so many designs and all, the important thing is to choose the right IOL design for the right patient, because every lens does not suit every patient. You have to customize. So all these lenses are available. It's good to counsel the patient, telling them that if you go for a monofocal, you're going to have distance vision, but not near. If you go for this XYZ lens, this is what you can expect. So you can, make a little chart. Your counselor can give them a little kind of a diagram as to what they'll be getting. So my approach is, first of all, I'm trying to find out whether the patient really desires spectacle-free vision. And let me tell you, it's 99% patients who wants to wear glasses. It's very few myopes who say, no, I don't look good without glasses. So I tell them, okay, you can wear a zero power glass. I mean, at least offer the best technology, And then you should generally have an idea whether the patient can afford or cannot afford. But even if your patient cannot afford, does not mean that he cannot have good vision, uncorrected vision without glasses. You can offer them monovision, distance, the first eye, dominant eye, you go for monovision, and the second eye you can go for slightly overcorrection. And if the patient can afford, understanding the patient's nature, his needs, whether the patient has any glaucoma, ERM, whether the patient is too finicky, such patients would be better off with EDOF. They will, at least you will save some chair time. And those who are easygoing, who do a lot of near work, reading, needlework, who enjoy the outdoors, who like to look out in the distance, who may be a golf player, who enjoy watching TV, they may be good patients, candidates for trifocals. Any case, I would say, EDOFs above 1.25, you must do a toric. But even if you have any amount of astigmatism, see how you can do your pre-op planning to reduce that astigmatism. Whether you want to do a larger incision, you want to change the site of incision, astigmatism absolutely must be reduced. And in trifocals, of course, you have to be very sensitive and you don't want any residual astigmatism. So this is roughly my approach to the patients. And of course, as I said, you understand the patient's need, you can blend it, you can mix and match, you can do mini monovision, or you can also counsel the patient that, okay, in EDOF, I've done one eye, but be patient. Within a week or 2 weeks, when we do the other eye, you're going to be much better off. So patient satisfaction is what we're all looking for. I would say it's inversely proportional to your pre-op expectations, the cost of surgery, and those who are very Google savvy. And is directly proportional to the chair time that you spend preoperatively, easygoing or hyperope patients. So in conclusion, we are still looking, the quest is on for the perfect presbyopia correcting IOL, and currently no one lens can suit all needs. Customization is the key, careful counseling, giving your patient realistic expectations, and ultimately trying to deliver your best. Thank you so much. So any questions more that anyone has?
Just a comment to what you added. Very important point which Dr. Ritu added was that some part of when she said about questioning the patient for our hobbies and all, it's very important that you do it yourself. And this is a small thing which I picked up from a close friend of mine who is a marketing genius. He's got a own marketing agency. He'd come to the clinic one day and was observing everything what was happening, waiting for his turn to come in. And he came in and he just mentioned one thing, that one thing wrong going on in your clinic is your optometrist is deciding about the lens with the patient, and they fix the surgery and they get out. I think that patient should come back to your cabin and you should discuss that final bit of that lens thing, because that makes a lot of difference. It increases the confidence in the patient. And very often you suddenly realize that the counselor or the optometrist has decided for a particular lens which is not really suitable for the patient.
So the way, Nitin, I do in my setup is that after I've seen the patient's undergone the biometry and all, then after that the patient goes to the counselor first. So the counselor will tell them about all kind of lenses. Of course, the counselor knows that if there's cylinders more than 0.75, she'll advise the toric, she'll give the packages. Then the patient comes back to me. Now, once the patient has a broad idea and they know their expenses also, which may be some out-of-pocket expenses, then you can fine-tune whether they want to go for an Indian multifocal, Indian EDOF, or you can. And as very rightly Dr. Parul said, do not judge your patients. I learned this once because one patient who was she had a dairy farm. Literally, she used to, take out milk. Never would I have thought such a patient would go for a multifocal, but she went for a multifocal in both eyes. So don't judge your patients as to what they would require. You can never tell. And some patients actually will come back to you and say that you never gave me the option. I can't see near, but why didn't you tell me beforehand? So give them all the options.
I think to add on to that, I had this patient who came with the son and the daughter-in-law, and the son and the daughter-in-law decided which lens to go to be put in the mother's eye. Mother was sitting there, but she was not a part of the discussion. After the surgery, the mother is continuously complaining, "मेरे में ये lens मुझे नहीं दिख रहा है अब नज़दीक का." So it's not only with the patient that we discuss, but I mean the relatives, but the patient per se needs to be discussed as well. Sometimes that is forgotten, that patient sits there, she is not answerable at that time, but later on she complains.
Yeah, one more thing is that, we should have a separate consent for multifocals. So, I mean, beyond your normal cataract surgery, I mean, maybe a few lines in your consent form only about multifocals and the fact that they may need, glasses even after surgery. That's again a safeguard.
Really important, because we've told them all of this, that you're going to need reading glasses, and they just come back and just flatly deny that you never told us. So I think that's really a good point to add into your consent, so that
I always make them write, I am unwilling for a toric lens inspection.
Okay, it's a bit much.
They should not go back and tell. And actually, there's an online assessor as to what is the visual needs. You can incorporate that into your assessment guide.
Yeah. Okay, we'll just take one photograph. I think we should be extended our time.